Okay, so I'm going to be doing my presentation on granulomatosis with polyangiitis, and I'm going to go over a case study. So just real quick, GPA is also known as Wegener's granulomatosis. It's small vessel vasculitis due to anti-neutrophil cytoplasmic antibodies, which I'll refer to as ANCA. It is a multi-system disorder that can cause significant morbidity and mortality. So now for the case report, we have a 40-year-old female who was referred from a local hospital, presented to ER with shortness of breath at rest and hemoptysis for the previous 5 days. The patient was healthy about 20 days ago, and she developed generalized swelling of her body, headache, and subconjunctival hemorrhage. She was treated for new onset hypertension, and 10 days later, after an episode of hemoptysis presented to a local hospital, she received antibiotics for pneumonia and then referred to another hospital due to worsening hypoxia and acute kidney injury. On presentation, she was an obese lady with BMI of 34 and mock dyspnea. On examination, she was conscious. Blood pressure was 130/80. Regular pulse was 120. She was afebrile. Respiratory rate was 36 breaths a minute. Her pulse ox-sat was 74% on Remair. She had also had pallor, periorbital puffiness, and lower limb dependent edema. Chest exam revealed bibasilar and inspiratory crepitations. Her antihypertensive meds included amlodipine, 5 milligrams daily. Initially, hemoglobin was 11.2. White blood cells was 24,000. Neutrophils 86%. Serum creatinine was 6.7. Blood urea was 210. Serum sodium 130. Serum potassium 3.7. Urine exam showed many red blood cells and proteins +3 and red blood cell casts. Here, this chest X-ray that showed bilateral middle and lower zone infiltration. Initial differential diagnosis was acute glomerulonephritis, either post-infectious related to pneumonia versus rapidly progressive glomerulonephritis, which I'll refer to as RPGN, due to vasculitis. Broad-spectrum antibiotics were initiated, and autoimmune serology were sent. Sputum for gram staining and cultures were also sent. ABG showed a combination of metabolic acidosis and respiratory alkalosis, and the ultrasonographic scan of the abdomen showed normal-sized kidneys with a grade 2 renal parenchymal changes. In this X-ray, it showed lower zone infiltrates more on the right side, the patchy shattering in the lower zones, and which tells me that it's indicating alveolar hemorrhage. Remarkable improvement noted on the CT, and showing disappearance of hemorrhage was shown by arrows in the figure B. So, chest CT done on the day of admission showed patchy granulomatosis haziness and geographic distribution. Most likely alveolar hemorrhage. Empirically, methylprednisolone was set 50 milligrams a day for 3 days, followed by oral 60 milligrams per day prednisone. And the plasmapheresis was initiated on second admission day due to RPGN and pulmonary vasculitis. The CT showed a lot of improvement. On the fifth admission day, results of ANCA titers were received, which came out to be very high. A third session of plasmapheresis was done after an interval of 1 day, and cyclophosphamide given on the 6th day. She had both clinical improvements in terms of her oxygen requirement, urine output, and falling serum creatinine. So further plasmapheresis was not done due to the cost and rapid clinical recovery of the patient. Renal biopsy was done on the 11th admission day, which revealed total of 9 glomeruli. 6 glomeruli showed fibroepithelial crescents with collapsed tufts. Immunofluorescence was negative, confirming polyimmune crescentic RPGN. She was discharged on the 15th day of admission on prednisone 60 milligrams a day and monthly scheduled doses of cyclophosphamide. Follow-up after about 6 months, 6 doses of cyclophosphamide showed Cushingoid phase, maintained O2 sats on Romer, and serum creatinine had improved to 1.1. Urine exam showed few red blood cells in spot urine for protein to creatinine ratio of 0.8 grams. At 12 months follow-up, in total 8 doses of cyclophosphamide monthly. Currently, she was stable on azathioprine and 5 milligrams of prednisone, followed by onco, which were in normal range, and she presented at 14 months with severe community-acquired pneumonia and rapidly deteriorated, requiring mechanical ventilation, and she unfortunately passed. So overall, just to kind of go over everything, the GPA is a small vessel vasculitis that involves the capillaries, arterioles, and venules. Clinically, it can involve a lot of different systems, commonly the pulmonary system, around 80%, upper respiratory tract, 86%, kidney, about 61% of the cases. Most of the patients really seek out medical attention for nasal and sinus symptoms, with or without involvement of the lower respiratory tract, which presents as hemorrhagic infiltrates and capitating lesions, leading to hemoptysis and respiratory failure in about half of those cases. Renal manifestations are hematuria, proteinuria, and RPGN in half the cases, while a quarter of the cases may reach end-stage renal disease in a few years. And this patient had pulmonary renal syndrome as lower respiratory tract involvement, RPGN. The mainstay of GPA diagnosis is serologic evaluation. Definitive diagnosis is made on a cytoplasmic pattern of 2 neutrophil cytoplasmic antibodies and ANCA. Proteins S3 ANCA, which is reactive toward proteinase 3, or myeloperoxidase MPO, called the C-ANCA and P-ANCA respectively. C-ANCA has sensitivity about 90% and specificity of 99% for GPA. And still, P-ANCA is positive in a quarter of the cases of GPA, and only about 5% of the cases GPA are negative for both C-ANCA and P-ANCA. And diagnosis in those cases is made pretty much on strong clinical interpretation. So renal biopsy showed segmental glomerular necrosis with crescent formation. Immunofluorescence studies are negative for immune deposits and complements, and papillary necrosis due to fibrinoid necrosis of vasa recta. Focal segmental glomerular sclerosis or renal limited vasculitis may be other presentations of GPA. Lung biopsy is more invasive, obviously, and it's usually not helpful due to the patchy involvement of respiratory tract. Invariably, the diagnosis is based on the presentation, serology, and renal biopsy. And this patient, the clinical presentation of very high serology was enough to guide the management and RPGN on renal biopsy, and which further helped confirm the diagnosis. So there's big improvement in morbidity and mortality has been seen with the use of immunosuppressive medications and plasmapheresis, and increases the chance of renal recovery when used along induction regimen. In patients who receive cyclophosphamide and corticosteroid for induction, the remission is seen in 75% of by 3 months, similar to our patient in about 90% in 6 months. Unfortunately, nearly half of those patients attaining remission will have at least one relapse in maintenance phase of azathioprine or methotrexate use is pretty well established. A greater risk of relapse has been seen in patients with C-ANCA positive or pulmonary involvement. Increasing the interest is developing an early detection of relapse for timely management with help of biomarkers such as a CXCL13 matrix, MMP3, and tissue inhibitor TIMP1. An increasing level of ANCA titers may help in predicting the early relapse, but it might not be sensitive. Rituximab is also a new addition in the of the immunosuppressive medications for GPA. There's been some recent trials that have been done, show its efficacy as induction therapy alone, also in patients with relapse due to the high cost of rituximab. Cyclophosphamide is still preferred as induction therapy whereas in resistant cases, rituximab is the drug of choice, and anti-TNF alpha biologics and mycophenolate mofetil have also been used in resistant cases. And just to kind of end things off, so early detection of GPA is really necessary since it may be the patient might rapidly deteriorate, like it did with this patient here, and high levels of suspicion and early initiation of management significantly improves morbidity and mortality. And plasmapheresis should be considered early on if acute kidney injury due to vasculitis is diagnosed. And these are my references. Thanks for listening.